Let's go on to one or two other unintended consequences. And I'd like to talk about the impact on continuity of care. This is slightly more subtle. Okay, so here's the graph that I showed you before. This is the interrupted time series where we measured quality at 2 points before and 2 points after QOF, and those lines are the ones I showed you before for asthma, heart disease, and diabetes. At these 4 points in time, we also gave the patients questionnaires. We asked them incidentally about their communication with their doctor, and that showed no change before and after QOF. They were just as happy with communication with their doctor. But we also asked them about their ability to see their own doctor. And what you can see here is that there was a clear but small step change in there was no change in the ability to see their own doctor before the QOF, and it went down and continued at a lower level after the QOF. Now, continuity of care, we all know, is very important in primary care. So is this an unintended consequence? This is, yeah, I can see some nodding. This is clearly a bad thing. On the other hand, I've told you already that GPs were starting to practice in different ways. They were employing more nurses, teams were getting larger, there was more specialization within general practice. So you might have one nurse who is responsible for diabetes and another nurse responsible for asthma. And this is the way, in a sense, which GPs found it was possible to deliver on quality across a wide range of conditions. So is this an inevitable casualty of a new way of working? Does it matter? I think these are questions to which there is no simple or straightforward answer. Then finally, in terms of unintended consequences, I want to ask what's happened to professional values. So here is the traditional GP. A few years ago, maybe. Friend of the family. I could hardly call this a home visit, but and life is very different now. We work in often quite large clinics with a whole range of staff supporting the GPs and trying to do different things. Dennis Pereira-Gray has published a paper a few years ago in which he very eloquently pointed out that life-saving used to be the province of the hospital and is now the province of GPs. So it used to be thought that general practice care, if you went back a couple of decades, was around broadly keeping people content. And if you really wanted to save lives, you went to hospital. But actually now our role is very different. Most lives are actually saved in general practice, either by preventive care or by good management of chronic disease. So our roles have changed radically, and can we still have this sort of relationship with our patients? And what happens if you just pay people to do things? Now, I have to say we have no clear answer to this from the UK. We continue, 7 years into QOF, to have a wide range of views on what this has done to the profession. And let me give you a few quotes now from some qualitative work that we've done with doctors to give you an idea of the range of views that are expressed. So here's a doctor who doesn't like it. He says, it will not provide the care for the whole person. It doesn't allow that. I've sat in this chair for over 20 years and I know my patients really well. It doesn't allow that. You can't count that. You can't count the caring element. But here's a doctor who disagrees. He says, I think it largely focuses on things which we should be doing anyway. It's just an additional motivation to make sure we're practicing good practice. And I think many GPs feel genuinely ambivalent. So here's a doctor talking. He says, I never use templates. I'm terrible. I mean, our nurses are great at ticking boxes. They're really good at that, and they love some structure. I find it quite depressing to think about, really. It just doesn't float my boat. And although I hate it, it's very paradoxical because I actually think it's a good idea. I think it makes things tangible and quantifies things. So this doctor is really ambivalent. And what he actually does in his clinical practice is he wants to carry on exactly the same, and he hopes that other people in the practice will deal with the quality things. He's a little bit like the fox in this picture. He's kind of hoping that if he just keeps quiet, nobody will notice. Well, somebody did notice. The next quote is from his senior partner. And she says, "Percentages are for wimps. I don't accept that once you've hit 70% or 90%, that's okay. It's not okay. It means that 10% haven't been caught. We developed this zero tolerance to blood pressures a while ago. No one is allowed to say, it's a little bit up, leave it. It's not acceptable. If you're not doing something about it, you need to be able to justify why not." And she goes on to say, "When we're not meeting a target, I will go in and speak to them privately. I did do one area of naming and shaming. That did work quite well. They don't want to be seen as a GP who's falling down." So you can see, even within one practice, quite a divergence of views and potential conflict on how you address these issues. Now, what does this tell us more generally about how doctors should be paid? Because one of his last slides was around different payment methods and saying there's no ideal payment method. And this, in a sense, is the broader context in which we need to understand pay for performance, and which you need to think about if you're becoming influential in its introduction in your country. Because different payment systems pull people in different directions. So broadly speaking, there are 4 ways of paying doctors. You can pay them on salary, which is the pay is independent of the work they do or the quality of their care. You can pay on capitation, in which you pay according to the number of patients on the doctor's list. You can pay fee for service, in which you pay for individual items of care, or you pay for quality, for meeting specific quality targets. So the question I want to ask is, what would you get without medical professionalism? What would these payment systems produce if doctors started acting unprofessionally? Well, this is what you'd get. Salaried doctors would do as little as possible for as few people as possible. Capitated doctors would do as little as possible for as many people as possible. Fee-for-service doctors would do as much as possible, whether or not it helped the patient. And doctors paid on quality would carry out a limited range of highly commendable tasks, but do nothing else. So the message of this slide is twofold. First of all, without the professionalism of our doctors, we are in a very, very serious situation. And therefore, as your healthcare systems develop, as your governments invent new and different reforms, our responsibility absolutely is to mold those systems so that they sustain medical professionalism and don't damage it. But the second message of this slide is that we probably need blended payment systems, that all these methods of paying doctors have benefits but potential drawbacks, and what many of our countries are looking for is what is the correct balance between these approaches to payment. So overall, my final conclusions are that I think financial incentives have a place in improving quality. They're not a magic bullet, and they need to be seen alongside other strategies for quality improvement. Quality incentives must support medical professionalism. And you must recognize that all interventions can have unintended consequences. And indeed, I've talked about one scheme being implemented in one country, and I think it's important to realize that the impact of incentives may depend very heavily on the detail of the scheme and exactly how it's implemented. But we certainly have got doctors in the UK doing different things. Now, we have a phrase in English which saying that getting doctors to do the same thing is as bad as herding cats, as difficult as trying to corral cats into one place, which everybody knows is impossible, unless you know how.